In this video, we'll talk about polyarteritis nodosa, how it presents, and how we can diagnose it in addition to the management. So we'll talk about polyarteritis nodosa, and polyarteritis nodosa mechanism, we don't know how it happens, but we know it is associated with hepatitis B and hepatitis C. When do we think about it? If you see a patient who has purpura in the lower extremities mainly, as well as they present with neuropathy 70% of the time. So neuropathy plus purpura, think about polyarteritis nodosa. Now you want to look for other symptoms like fever, weight loss, sometimes bloody diarrhea, and other vasculitis symptoms like chronic fatigue, etc. And the patient will give you a history of hepatitis B in around 30% of the time. If they don't give you that and you diagnose them with polyarteritis nodosa, we need to check hepatitis B to see if they had it already before and they don't know about it. Now, what other workup you need to do when you suspect a patient having polyarteritis nodosa? So you will do a BMP and you want to check the creatinine if there is acute kidney injury. Note that in polyarteritis nodosa, the acute kidney injury is mainly ischemic kidney injury. It's not the glomerulonephritis as in vaginal granulomatosis or Goodpasture syndrome. Here it's more of acute tubular necrosis. This is an important point, which means in the urine analysis there will be no RBC casts or dysmorphic RBCs, which are characteristic of glomerular disease. You want to check for hepatitis B and hepatitis C as we mentioned, and you want to check for ANCA as well. If that is negative, then this is likely, or this goes with polyarteritis nodosa. If it's positive, then polyarteritis nodosa is very unlikely. Now, you need to do imaging to confirm your diagnosis, and here we are talking about CT angio or MRA. And what we are looking for renal microaneurysms. And remember, these are the ones that causes ischemic kidney injury and causes acute tubular necrosis. Now let's talk about the diagnostic criteria. So the ACR has criteria which constitute 3 out of the following 10. I'm going to mention the last 2, biopsy positive or arteriography positive. The reason I mentioned these first, because you have to have either one of them for diagnosing or as part of the criteria. Now the other 8 include neuropathy, testicular pain because the vasculitis can be localized sometimes and involve single organs like the testis only. And they as well might have myalgia, they will have as well creatinine elevated secondary to acute kidney injury, hepatitis B being positive, neuropathy, etc. You don't have to memorize these, you just try to make sense of them when the patient presents to the clinic or if you see them inpatient. Now, let's talk about the prognosis a little bit. If we don't treat these patients, around 10% only survive after 5 years, while if we treat them, 80% can survive in 5 years on average. Now, the treatment we're talking about is steroids, and you can add DMARDs if the patient has severe symptoms. And important to know, potentially question, when do you do plasmapheresis in polyarteritis nodosa? Only if hepatitis B positive. The reason is this is the only situation where plasmapheresis showed benefit in polyarteritis nodosa. Important thing, history of polyarteritis nodosa, and they have hypertension. The drug of choice is going to be ACE inhibitor, similar to scleroderma crisis, which we mentioned before. And that's it for polyarteritis nodosa. Hope you guys learned something. See you in the next one.